Welcome to OsteoBites. My name is Christina Iptoma, and I am mom to OsteoAngel Dylan, and I'm the Director of Scientific Programs for MIB Agents. Today on OsteoBites, we're talking with Dr. Amanda Marinoff from UCSF, who will be discussing her research on MYC amplification as the first genomic prognostic biomarker in osteosarcoma, and how it may be used for risk stratification in future clinical trials, to inform conversations with patients and families, and how it may serve as a potential therapeutic target in the future. Thank you so much, Dr. Marinoff, for joining us on OsteoBites today. Dr. Marinoff graduated from Harvard Medical School and completed her pediatric residency at Boston Combined Residency Program, during which time she worked with Dr. Katie Janeway on elucidating the genomic landscape of and novel genomic biomarkers in osteosarcoma. She's currently completing her fellowship training in Pediatric Hematology Oncology at UCSF, where she is focused on developing novel genome-informed therapeutics for osteosarcoma under the mentorship of Dr. Alejandro Sweet-Cordero. She plans to develop an active clinical and translational research program focused on conducting early phase precision medicine-oriented trials for patients with advanced sarcomas. And before we get started with Dr. Marinoff's presentation, I just have a few events that I wanted to share with you all. First, if you're in Boston, right after this podcast, you need to get on the T, take the green line to Arlington, and head straight to Davio's Back Bay for free drinks and snacks, and end the day with some good vibes hanging out with the MIB Agents crew and the Boston osteosarcoma community. And we have another event in Boston tomorrow. It's not too late to sign up for the Healing Hearts Retreat for bereaved osteosarcoma patients and parents on Friday in Boston. And email Casey to get more info, and we'll put her email address in the chat. And last announcement is Factor registration is now open. So we'll put the registration link in the chat also. It's going to be June 23rd to 25th in San Diego. And you know what they say about Vegas, you know what happens in Vegas stays in Vegas. So Factor is the opposite of that. What happens at Factor has ripple effects way beyond, and you're going to get a dose of inspiration and hope that will last long after San Diego. So please come, you'll be very happy you did. And before we start, I just want to thank our sponsor for this episode, BTG Specialty Pharmaceuticals. BTG provides rescue medicines typically used in emergency rooms and intensive care units to treat patients for whom there are limited treatment options. They are dedicated to delivering quality medicines that make a real difference to patients and their families through the development, manufacture, and commercialization of pharmaceutical products. Their current portfolio of anecdotes counteracts certain snake venoms and the toxicity associated with some heart and cancer medications. Their drug Veraxis is for high-dose methotrexate toxicity. So with that, Dr. Marinoff, if you want to go ahead, you can share your presentation and we'll get started.
Thank you so much for that introduction, Christina, and for having me today on the webinar. It is really such an honor to be here. As Christina shared, I'm a pediatric oncology fellow, and I think taking care of pediatric patients with cancers and thinking about how to improve their care is really the best job in the world. So I'm excited to talk to everyone today about how we can understand MYC as a way to make it better for children with osteosarcoma. I'll share first that I developed my interest in osteosarcoma during my time in medical school while I was on my surgery rotation, which quite honestly was not my favorite, but ended up being a very formative experience because I met a very remarkable young man during his first open chest surgery to remove metastatic osteosarcoma nodules from his lung. And when he woke up and in the ensuing months, he would later introduce me as to his nurses and his doctors as, hey, this is Amanda. She touched my heart. No, literally, she was inside my chest. And I will say Miles was his name from a metaphorical standpoint, certainly touched mine, and both his life and his ultimate passing inspired my interest in pediatric oncology in general and my interest in studying osteosarcoma specifically. So with that, I do have a couple of disclosures. First, I want to make it better for children with osteosarcoma and their families. And secondly, I believe we can and we will. Just a brief bit of background that this group likely doesn't need a whole lot of, just to sort of center our why. Over the past 4 decades, we've had limited progress in terms of treatment strategies, outcomes, and our risk stratification strategies. This is a diagram, a busy one, that shows the survival curves based on the last 4 decades of clinical trials. And the punchline here is we haven't made much progress, but it hasn't been for lack of trying. We see each of these lines is a different trial. The green ones include 4 different chemotherapy agents. The blue ones include 3 different chemotherapy agents, and the red ones include 2. And we see the green and blue do a little bit better than the red, but not much better than each other. That more chemotherapy isn't better. And so our standard of care has been, in North America at least, 3 chemotherapy agents: MAP, methotrexate, Adriamycin, and platinum is what it stands for. Patients get chemotherapy up front, then they get surgery to remove their primary tumor, and then they get more MAP therapy. More agents from the standard chemotherapy point of view has not resulted in better outcomes. And so we need to think outside the box. We need to better understand the biology and come up with different strategies. And so that affords us a number of clinical challenges and opportunities. The first of which is our very poor outcomes, specifically for patients with advanced osteosarcoma, and those are those with relapsed or metastatic disease. We have blunt and imperfect tools for risk stratification. We use the presence of metastasis to define high-risk disease if patients weren't able to have a complete resection of their primary tumor. And then we look at histologic response to chemotherapy, meaning when patients have their tumor removed surgically, the pathologist looks at it under the microscope and says, what percentage of these cells are dead or necrotic, as a proxy for its response to chemotherapy. But that's not a perfect tool either. There are some patients who have a poor response histologically who do well, and vice versa. We're not using any molecular markers in our risk stratification schema. And even when we can identify high-risk patients, we don't actually have therapies available yet to intensify or target their specific disease. And there's no targeted therapies that we're yet integrating into our regular clinical care. And on top of that, osteosarcoma has very complex genomics and is an extremely heterogeneous disease. But with these challenges, Houston, I think we have a number of opportunities. To just briefly review the chaotic genome that we have now elucidated through a number of landmark sequencing studies over the last several years, osteosarcoma is characterized by widespread copy number alterations. There are some pediatric cancers where we have sort of a single fusion driver event that we know to be present in almost all patients with that disease subset, but that's not at all the case for osteosarcoma. This first top plot is what we call a copy number plot. The numbers on the x-axis are just chromosome numbers. And in a normal genome, we would not see any of those blue valleys or those yellow and red peaks. It would be quiet, but we see here that there are a number of copy number losses shown in blue, and then gains shown in yellow and red, all throughout the genome. And then these circles at the bottom are pretty, but are evidence of more genomic chaos. We call these circles plots, and they show an event that we call chromothripsis, which is basically taking the genome and then shattering it and causing a number of widespread changes from a single event. And we can see first and foremost that there are different colors within each plot, and then compared to one another. Osteosarcoma has been described as sort of like a snowflake. One physician scientist said to me, if you have a genome that looks the same from one patient to another, you've probably contaminated your samples. That's how heterogeneous this disease is. We see here that the purple lines indicate translocations, orange lines are inversions, green lines are duplications, and blue lines are deletions. And so our question and our task is, can we find some signal amid the noise to define clinically relevant subgroups that will allow us to predict how patients will do, how their disease will behave, who will respond to standard therapy, and who needs different therapy up front and not just at relapse that really fits with their disease biology. So with that, I'll share some data from a project I worked on under the mentorship of Dr. Katie Janeway at Dana-Farber, at which we looked at a high-risk pediatric cohort of patients with osteosarcoma that were from two studies. One was the profile study, which sequences all patients that are seen at Dana-Farber with cancer diagnoses. And then a second is from the GAIN cohort. It stands for Genome Assessment Informs Novel Therapy. It's also called the ICAP2 study. And that enrolled patients from 12 different institutions who had high risk, relapsed or metastatic extracranial solid tumors. And so we knew that this was a relatively high risk cohort just by virtue of their enrollment on the GAIN study. And that was on purpose because this is really the group that we think needs a better understanding and for which we need better therapies. So we first looked at their survival curves overall and took a look at the different clinical prognostic markers to see if there was any signal for clinical factors that could differentiate subgroups. And unsurprisingly, we see a difference in terms of patients who had localized disease shown in yellow versus those who had metastatic disease shown in gray. And the overall cohort is shown in blue. And we see that the 3-year overall survival for those with localized disease was 77%, whereas those with metastatic disease was 45%. And we see a similar pattern in terms of event-free survival. Of all the clinical prognostic factors that we looked at, the presence of metastasis was the only one that was statistically significant, including the percent necrosis or the response to chemotherapy when we look at those tumors under the microscope did not turn out to be statistically significant. So then we said, can we actually take a look at their genomic landscape for a couple of reasons. One, this is a group of relatively advanced high-risk osteosarcoma. Do their alterations look any different than kind of osteosarcoma all-comers? And secondly, can we identify any biomarkers that can be used for risk stratification and or a potential therapeutic target? This is a busy oncoprint, which shows the most commonly altered genes in our cohort, shown on the left over here, along with their clinical characteristics up top. Each of these bars is a different patient with a different alteration. And this sequencing was done based on targeted panel-based sequencing called OncoPanel, using a next-generation sequencing capture-based method. And that's a clinical tool that pretty much every patient who gets treated on or off trial gets sequenced with. And we saw here that MYC was amplified in 12% of patients with osteosarcoma, and that's somewhat similar to what's reflected in the literature, which has a somewhat broad range from somewhere in the 10 to 40% range of patients with MYC amplifications, depending on the sequencing method and the cohort that's used.
Dr. Marinoff, can I just throw out a couple questions here? So for that, do you know, because I mean, MYC is kind of a common mutation in other more common cancers. And do we have a sense of kind of how that 12% compares to other cancers?
Yeah, that's a great question. MYC is not it's not a new gene that we know of, and it's not unique to osteosarcoma. In fact, MYC-related pathways are thought to be dysregulated in about 70% of cancers. A recent pan-cancer analysis using the TCGA cohort, looking at 9,000 samples, found that it was amplified specifically in 28% of cancers overall. Probably breaks down differently in terms of different cancer subsets. And then within cancers, I think probably different subsets within there. And it depends on how you define MYC alteration and what methodology you use to sequence it. But overall, it's a lot of cancers across the board.
Right. And just this list is kind of prompting me, you might be getting to this later, but I'm just curious, when you see the MYC amplification, is it commonly paired with or with like showing up with other mutations? Like, does it tend to show up with other mutations, or is it just kind of its own thing?
That's a great question. And I think it's one that we're still exploring to look at which which genes are co-amplified, what that means prognostically for our patients, and which ones with which it's mutually exclusive. We saw a signal here, and that's been shown in a couple of other small studies. If you look at MYC and CCNE1, they seem to be tracking together, and there was a recent paper by Danoon and group that showed that those patients seem to have a particularly poor prognosis, but I think that remains to be validated, and other interactions with MYC is a really important question for us to explore. So of all of the genomic markers that we looked at, MYC amplification was the only one that was statistically associated with survival in our cohort. And that's shown here in our Kaplan-Meier curves. The top curves are our overall survival in A and event-free survival in B for our primary analytic cohort. Those are the 92 patients that I just described. And we see in blue those with in red, those with MYC amplification defined at a copy number threshold of greater than 7 have a significantly worse overall survival and a trend toward worse event-free survival than those without MYC amplification, or those with less than or equal to 7 copies of MYC. And I'll talk on our next slide about kind of how we chose that threshold, why it's good, why it's not great, and where we go from there. We also looked at a validation cohort from 86 patients from Memorial Sloan Kettering, because we were wondering, hey, this is a high-risk group of patients. Is MYC really just like we have more patients with metastatic disease? Is that what's going on here? Is that just a proxy? What if we looked at a more homogeneous group of patients that are more kind of standard risk in localized patients only? And so these were 86 patients with localized disease. And indeed, these patients, among those with MYC amplification shown in red, and here MYC amplification is defined differently as a 2-fold change or greater, did significantly worse than those without MYC amplification from both an overall survival standpoint and an event-free survival standpoint. Now, clearly, these are not exactly comparing apples to apples. We're using different sequencing methodologies. The Memorial Sloan Kettering used a different targeted sequencing-based panel called MSK Impact. We have different definitions of MYC amplification, and so it's really hard to completely synthesize all of this data. However, I do think that the fact that we had 2 distinct and independent cohorts using different bioinformatic pipelines, using different sequencing tools, different definitions, what we're still kind of seeing at the crux of it is MYC amplification does seem to have an association with poorer outcomes in both of these cohorts. And I think really it calls to the robustness of that observation and a call to continue to explore and validate that. Which cutoff made the cut? Well, I told you we chose copies greater than 7, and we did an analysis looking at association at each of these copy number thresholds. And you can see here, actually, at copy numbers greater than 4, we do see a statistical significance in terms of association with survival. P here is less than 0.05, but we see that this association doesn't hold up at copies greater than 5 and 6 at those thresholds, potentially suggesting that at these lower copy number amplifications that there's a lower signal to noise ratio. But then at 7 and then greater than 8, 9, and 10, we see consistently significant association with poorer outcomes with MYC amplification. And so again, we chose our copy number threshold as 7. This is starred here in blue. It's not yet a gold star because again, it needs to be validated in additional cohorts, ideally using the same sequencing and bioinformatic pipelines and in a more homogeneously analyzed group. One question that sometimes comes up is more MYC worse? And I think we don't yet know that. And I think there's a lot of layers of complexity, but I'll just share a few clinical anecdotes that I think are at least intriguing and merit further looking into this question about how the number of copies of MYC may relate to the disease's behavior and the clinical outcomes for our patients. So we saw 3 patients with extremely high MYC amplification. And they had particularly aggressive courses. In this case of patient 6, we see in A, the copy number plot with absolute copy number here on the y-axis, and we see actually almost 80 copies of MYC. We were just talking about in the 4, maybe 4 range, 5, 6, 7. This is 80 copies of MYC. And this patient presented at a younger than average age. Usually we see preteens and adolescents. This patient presented at the age of 7. And in B, we see kind of a snapshot of their PET scan, and all of these black spots are areas of metastasis. These are abnormal areas that light up on the PET scan and show diffusely bony metastatic disease, in addition to lung metastases in this very high MYC amplified osteosarcoma. This MYC amplification was actually detected in circulating tumor DNA in circulating tumor cells, which is not yet something that we have fully integrated into clinical practice, but we had the suggestion here that MYC amplification could be detected, and this is something that could potentially, if validated, be used to track response to therapy and then minimal evidence of relapse before frank relapse. And again, this patient had remarkably metastatic disease at presentation, and then progressed after 4 cycles of our standard MAP therapy, which is quite unusual to progress while on therapy, and then ultimately died 10 months after presentation. In a second case, in case 24, we see MYC is amplified to a little bit over 30 copies. This patient presented with initially localized disease at the age of 16, and based on our current risk stratification schema, we would say that patients with localized disease tend to have relatively favorable outcomes with overall survival in the 60 to 70% range. However, this patient had a recurrence 6 months after completing their MAP chemotherapy and then died within 3 years of presentation. And then similarly, this case 32 had a MYC copy number level around 30, and this patient also presented very young at the age of 6. This patient had localized disease and so was thought to potentially have a relatively favorable outcome, but had a poor response to chemotherapy based on looking at their tumor cells under the microscope, and then died of disease a year after they presented. So again, all of these are very much anecdotal, but I think are outliers that warrant, that are sort of food for thought and fruit for further investigation in terms of the relationship between the number of copies of MYC and the disease presentation.
Dr. Marinoff, sorry, just so I'm understanding this off. So is the x-axis there, that's kind of longitudinal over time from like diagnosis over the course of their treatment? Is that correct? That you're
copy number plot?
Mm-hmm.
Great question, and sorry for not clarifying. That is just the across the chromosomes and where MYC lands. So the y-axis doesn't really, the x-axis doesn't really have a patient-specific relevance. It's really that y-axis showing the peak in terms of the absolute copy numbers. And I'll talk a little bit later about some emerging data indicating that MYC copy number at the genomic level really isn't the full story, and that we need to be thinking about other levels of regulation, including the way that it's expressed and the way that it's epigenetically regulated.
Because I'm curious if you have data showing like longitudinal data where you can kind of see at diagnosis, but then with progression and metastatic disease, if you're seeing, like, is it common to see kind of MYC appear at diagnosis and then perhaps like the copy number changes like increase over time, or like can you not have any MYC amplification at diagnosis, but then, you know, 2 years down the line?
Great question. I have this slide toward the end, but I'll share it now. Thanks for asking that. I think the question is right on the money. We really need to understand the genomic evolution of osteosarcoma and the relationship between primary tumor, metastatic tumor, and that is really through collecting longitudinal serial samples over time and matching the initial primary tumor to their later recurrent and or metastatic samples. Thus far in the literature, we don't have a lot of that data, but I know there's a lot of interest in it. Dr. Janeway and I did an exploratory analysis in our data set of 92 patients. We had 13 patients who had multiple samples. They weren't all perfectly matched of primaries to their metastatic tumors, but we at least got to start to dabble in some patterns. And we see here MYC up top. Again, each of these vertical columns are an individual patient. And we can see in some cases, MYC was present, surprisingly, in the primary tumor sample, but seemed to have disappeared in the metastatic sample. In other cases, and darkness is kind of correlates with number of copies, whereas lighter is fewer numbers of copies. We had fewer copies that were detected. And in other cases, in the metastatic sample, we had more copies detected. So it's a little bit all over the map, and I think remains to be explored. I think part of this could be technical issues. It could just be the way that we're looking at it and detecting MYC. It could be related to tumor purity, but some of it could potentially be a real biological phenomena. There is some evidence in vitro, at least in the breast cancer world, that that breast cancer cells downregulate MYC, at least transiently, to mediate metastasis. So I think it's tempting to say that more MYC equals more metastasis and draw that line directly from A and B, but I think it's probably not that straightforward. And doing further studies in a larger cohorts and really matched samples is going to really help to disentangle that, to understand that genomic evolution in MYC and in other genomic alterations. I'll just share here. So my interest in MYC developed from that study that I did with Katie, but there's been some a lot of emerging evidence recently over the past few years in a few different cohorts indicating the same association of MYC amplification with poor outcomes. This was a study from Chen et al. That looked at 30 different tumors and looked at whether MYC expression was more prevalent in patients who developed metastatic disease. And we see here this red box and whisker plot tends to have higher levels of MYC. The levels of MYC in a log fashion is on the y-axis than those who did not develop metastatic disease. Another way of looking at that is through the survival curve, where patients with high MYC amplification, shown in blue, have a lower likelihood of metastatic-free survival. And similarly, a study by Feng et al., which looked at 70 different tumors from a tumor microarray and then validated it with a publicly available data set, showed that those with MYC high expression, here in yellow, had poorer overall and progression-free survival relative to low MYC, shown in pink. And then Danoon et al. Looked at 3 additional publicly available data sets and found that MYC amplification actually was the one signal that differentiated pediatric tumors, or was enriched in pediatric osteosarcomas relative to their adult counterparts. And again, at least in the localized setting, they didn't have enough numbers exactly in the metastatic MYC amplified cohort, but MYC amplified localized osteosarcoma with does just as bad as the metastatic group with MYC wild type, and much worse than those who have no MYC amplification and localized disease. And so with all of this, I wanted to share part of my vision for what our path forward may look like. Before I dive into that, I briefly wanted to touch on kind of what is MYC, what is its normal structure, and what is its function. Here on to the left, A shows a biocomputational method for taking a look at how disordered a protein structure is. And we see a very squiggly line with the disorder score on the y-axis, which indicates that at various domains, MYC is very disordered, meaning that their 3D structure is really unstable. And the reason that that's important is that it has historically made it a really difficult target to drug. I'll share in the subsequent slides ways in which we're getting around that. But that is just to say that it's an intrinsically disordered protein. MYC is part of a superfamily with 3 different isoforms or paralogs. c-MYC is the one that's involved in osteosarcoma. We see some shared domains. NMYC, you may have heard of, come up in neuroblastoma, and LMYC is involved in lung cancer. And C shows an X-ray structure of MYC with its binding partner MAX binding to DNA. And in the normal physiologic healthy state, MYC is very tightly regulated and can bind to a broad but selective set of high affinity target genes, allowing for appropriate transcription and repression of genes that allow cells to proliferate and die when they're under damage or stress, and then overall to continue to thrive. But in the deregulated state, MYC can kind of go wild. It can willy-nilly bind to both the high affinity target genes and low affinity target genes, resulting in uncontrolled cell division, proliferation, and tumorigenesis. This is a classic diagram of the hallmarks of cancer, and MYC is really at the center of all of them. It is a very smart gene that, as we discussed, is involved in sustaining proliferative signals. It evades growth suppression, avoids immune destruction, enables replicative immortality, promotes inflammation, invasion and metastasis, the development of additional blood vessels or angiogenesis. It promotes genomic instability and mutations, and then escapes programmed cell death or apoptosis, and then is also involved in deregulating cellular energetics and metabolism. And so it's involved in many cancer pathways, and thus there are many opportunities to think about therapeutically exploiting this gene. And so this is my version, my own schematic of a multiohmic approach, and where I think we can and will go with this. First, I think we can and will ultimately use MYC as a biomarker for risk stratification in counseling patients and caring for patients, and in the design of our future clinical trials. We're not yet there. As I discussed, we don't yet have a copy number threshold, and this will really necessitate broad data sharing and validation in a prospective manner. I think MYC is not only a driver of a number of different cancers, but really can be used as a driver of biological insights to understand those cancers and develop better approaches to treating them. And then despite the fact that it's been called undruggable, I think there are many efforts that suggest that it ultimately can be a tractable therapeutic target. So for the first aim in terms of incorporating it as a biomarker and really bringing osteosarcoma into the precision oncology space, this is an area that I'm passionate about, and I think will really require continued broad data sharing, aggregation, and harmonization of data. I think in our GAIN study, where we had 12 different institutions and multiple different cohorts of data over decades, we only had 178 patients and samples, and so I think we need to continue to be vigilant about our data sharing and really linking that omic data to the clinical data to say, how do these biological insights really impact patients, and what can we do to bring that into their care? There are a number of really wonderful initiatives, including AACR's Project Genie and the CCDI, as well as the Target Initiative, that really gets at this, the importance of linking those omic data with the clinical, and then helping us to bring it to bear in patients. I shared this slide as sort of a teaser of biological insights that beg more questions that will hopefully beget some additional insights. Again, I think we need to study the genomic evolution and understand MYC's role in from the primary tumor to the recurrent to the metastatic tumor. I'll skip over that. These are data from Alejandro Sweet-Cordero's lab, of which I'm now a proud member, that I wanted to share, which starts to get at the question of, is MYC copy number everything, and how does it relate to MYC expression? And A just shows from an RNA-seq standpoint or expression standpoint that it is extremely heterogeneous over a number of osteosarcoma cell lines and PDX models that we see. Each of these dots are a different cell line. There's high and low expression ranging the full range. When we look at the RNA-seq landscape in terms of MYC expression, we again see extreme heterogeneity. And then when we break that down and see to look at MYC high expression versus, it's shown in orange, and MYC low expression shown in blue, we see differentially expressed genes in each of those subgroups, which I think is interesting in terms of understanding potentially distinct groups of biologically groups of osteosarcomas that clinically and biologically behave differently and maybe would respond differently to different treatments. And then D, again, is copy number changes at the genomic level the same as expression? I think this is a clear answer that no. Here on the x-axis, we have copy number less than 2, 2 to 4, and then 4. And we see a really broad range of expression at the RNA level within each of those groups, and they're overlapping with one another. And so there must be some other mechanisms to regulate the ways in which MYC is actually expressed. It probably behooves us to take into account, again, not just the genome level changes, but how does that relate to transcriptome related changes and expressions and changes in the expression profile of MYC. And there's been some additional really nice work done by a lab member, Eunice Fuentes, who is a wonderful member of the lab, who sits by my bay, who has done some work looking at epigenetically defined clusters based on MYC expression using a methodology called ATAC-seq. And I won't go into the full details of the approach here, but what we can see is a red cluster and a blue cluster. And the red cluster are those of osteosarcoma cell lines and patient-derived xenograft models that have high MYC expression. And they cluster away from those of commercial cell lines and those that do not have high MYC expression. When they then did a transcription factor enrichment analysis to say, well, how does this actually affect what's downstream of MYC? Lo and behold, we found different transcription factors that were enriched in each of these groups. To the right here in blue, we have the high MYC cluster versus the low MYC cluster. And I think this is really exciting given the really profound heterogeneity of osteosarcoma to be able to distill this complexity into two seemingly biologically and clinically relevant groups. We can then start to think about integrating these kinds of groups into our preclinical and ultimately our clinical trials. Can we drug the undruggable? Well, Nelson Mandela and a lot of scientists say it always seems impossible until it's done. And indeed, we have many efforts. Again, MYC is a hotspot for nearly all tumors, and so there are many efforts across cancer research for direct and indirect small molecule inhibition of MYC. And here's just an overview of some of those strategies, and I'll highlight a few of them. As we've shared, MYC needs its binding partner MAX to do its function, and so interrupting that the binding of MYC to MAX is one attractive strategy. Omo-MYC is the most commonly studied in the preclinical setting, but there's a whole host of others and efforts to bring those into clinical trials. Targeting MAX itself is another strategy. Targeting aurora kinase A has shown preclinical and some clinical efficacy. There's a compound called alisertib, which is in trial. Aurora kinase A inhibits the degradation of MYC. So if you can inhibit aurora kinase A, perhaps we can promote the degradation of MYC. And we're seeing that as a potentially efficacious signal in other tumor types as well. And then bromodomain inhibitors, or BRD4, is a subclass that's also gained a lot of interest in the preclinical setting, with efforts to bring them into trial. If you Google MYC drug, I think you get over 8 million hits. So there are lots and lots of people working on this. Highlighting a couple of other potential strategies and sort of a broader view on precision oncology in the osteosarcoma world. This is a nice schematic that was generated by Leanne Sales in a landmark paper that she and others in the Sweet-Cordero lab produced back in 2019, which showed that there are biologically distinct clusters that can be formed based on specific genomic alterations mutations, and that these are differentially responsive to different therapies in patient-derived xenograft cell lines and in mouse models. And highlighting MYC here, we see a differential sensitivity of MYC amplified PDXs to CDK inhibitors, specifically thought to be related to CDK9 inhibition. And I'll briefly go over some of her really nice in vitro and in vivo work. These are just two cell lines that show MYC amplification here. This long bar is MYC in the two different cell lines that are derived from patients' tumors, confirming that MYC is actually expressed is a Western blot showing these dark bands with expression. These are the control ones where we knew that MYC wasn't amplified, and indeed we don't see a band there. In this cell line, when it is treated with vehicle or the control, we see that it grows out of control. But when it's treated with this pan-CDK inhibitor, we see stopping of the growth and sort of a stagnation of tumor volume here in green. Another way of seeing that is that we see a significantly smaller tumor volume in the treated group relative to the control. And in some cases, we see, again, lower rate of growth or a lower percent change in volume. And in some cases, we even see shrinkage. So some exciting data that, of course, would need to be validated in humans. Similarly, in osteosarcoma, in the second cell line with MYC amplification, we see the treated group has significantly smaller tumor volume than those that are treated with the vehicle. And she confirmed using a Western blot that this is actually mediated through repressing the expression of MYC, where with the vehicle treated group, we see the bands show up, and then when it's treated with the drug, the CDK inhibitor, we no longer see MYC expressed. And here's an assay showing that treatment with the CDK inhibitor increases apoptosis and decreases proliferation. MYC is thought to be involved in the DNA damage response through directly inducing DNA damage with reactive oxygen species, and when it's functioning normally, actually acts to help upregulate p53 and allow for apoptosis. But when it's dysregulated, apoptosis is not able to occur. We see a specific signature within osteosarcoma tumors and in cell lines we call signature 3. That's quite similar to BRCA deficient tumors that are common in breast and ovarian cancers. And that data in combination with some in vitro data showing some response to DNA damage targeting agents has formed the basis of a new clinical trial. It's a phase 2 study showing olaparib, which is a PARP inhibitor, in combination with ceralasertib, which is an ATR inhibitor. Both of those are involved in the DNA damage response pathway for patients with recurrent osteosarcoma. And it's possible, and there seems to be a signal, at least in the breast and ovarian cancer world, in which in cancers where there is increased MYC expression, they seem to be differentially responsive to these DNA damage response targeted agents. And then lastly, but certainly not least or comprehensively, MYC has also been shown to be a global regulator of the tumor microenvironment or immune response, including regulation of PD-L1 expression. Checkpoint inhibitors are a hot topic in a lot of other cancers, and it is possible that through understanding the mechanisms of MYC, what regulates MYC and what MYC regulates, we may be able to use immunotherapeutics to differentially target MYC overexpressing tumors. And so my overall summary, that again is just a real bird's eye view with lots and lots of, I could have had infinite number of boxes within each of these, and there are probably many other big boxes, but I think we can and will bring MYC into clinical trials and into standard patient care as a biomarker for risk stratification through continued broad data sharing, continued efforts for banking, prospective validation as a biomarker, and linking clinical biochemical and genomic data. We'll continue to use MYC as a driver of biological insights with a specific focus on understanding its role in metastasis, DNA damage response, the tumor microenvironment, what regulates MYC and what MYC regulates, and then as a potential therapeutic target through that busy slide that I showed earlier, and many, many, many more efforts. So with that, I'd like to say a sincere thank you to all of you for listening and for all you do to make it better for kids with osteosarcoma and their families, to Katie and Alejandro, who have both been wonderful, wonderful mentors, and to both laboratories, and to the many, many patients and their families who relentlessly inspire me each and every day. So with that, I'll take any questions or comments.
Thank you so much, Dr. Marinoff. That was, wow, so much, that was really interesting, really, and hopeful too, because, MYC is a tough one, but I love that you were kind of able to help identify possible avenues for attacking MYC. So that is great. Everyone feel free to put any questions in the Q&A if you want to throw some of those out. I was wondering, one of the drugs that you mentioned, or inhibitors, was a CDK inhibitor. And I was wondering, are there any drugs that are currently in trial for that, or any that are FDA approved?
That is a great question. I am not certain about whether it's approved in other settings. As of yet, I don't think that there are any currently in clinical trials in patients for osteosarcoma, but I think there's enough promising preclinical data that we will get there if we're not there yet.
Mm-hmm. And then just so I understand, and also I'm just kind of thinking, as a parent, thinking about, okay, if I see MYC show up on one of our reports and what that means. So you were talking about the difference between just expression versus copy number changes. And so I think there's maybe a couple of ways that people might get to understanding whether or not there's kind of MYC involved in their tumor, right? One might be the IHC staining. Mm-hmm. And so that just kind of shows expression, right? Maybe. Yeah. And then there's actually seeing it in in a genomic sequencing report. And but there, even I guess you would actually need to have the copy number change data to kind of understand, I guess, where you are in that risk threshold. Is that correct? So it's not just do you have MYC amplification? There's kind of that further step of well, to what degree?
Absolutely. I think you are really honing in on it. It is clear as mud. What is MYC amplification? Is all MYC amplification the same? How do we define it in both the research space and the clinical space? I think is really challenging and has really important implications for patients and the way that we approach their treatment and the way that we approach counseling. I can only imagine how anxiety provoking it would be to hear that this is a MYC amplified tumor without putting it in context in terms of, is this based on expression? Is this really high MYC amplification? Are we seeing low MYC amplification signals? So I think it really, really behooves us to figure out what MYC amplification means, what level of MYC amplification is probably okay, and what level of MYC amplification should say, let's call in all the troops and think about the best possible strategies for treating that patient. And I'm hopeful that we will identify at least a relative copy number threshold or expression level, and that we will not wait until those patients relapse or do poorly, but rather say upfront, we know that this is a poor prognostic marker, so we just need to be really aggressive with our therapeutic strategies. And I think we will get there, but I think right now we are not quite sure how to interpret it, the increased MYC expression, or exactly what to do with it. But I think knowledge is power, and we're gaining that knowledge. And I think there seems to be consensus among the field that MYC is of interest, and we need to figure out what it means and what to do with it.
Yeah, and actually, so right to that point, we actually have a question from someone asking that based on this research and analysis, do you feel like for osteo, genomic sequencing should happen at primary tumor biopsy, and should that be the standard of care, knowing that it could be this important prognostic biomarker?
Yes, you're asking some points bias, but I think that all patients should have at least an analysis of whether MYC is present. And I think if possible, all patients should have some degree of sequencing of both their tumor for somatic alterations as well as germline sequencing, since we know that a lot of osteosarcoma is related to or a fair proportion is related to germline alterations. And I think in this rare tumor where we need every bit of knowledge that we can get, it will help us to better understand the tumor and treat patients going forward. So I think both for the individual clinical care, it's useful to have that sequencing data. I hope it only becomes more useful such that we're actually able to say, like, we're going to treat you with regimen X based on your sequencing. I think we will get there, but I think we will only get there if we get more genomic data that's linked to the patient, if that makes sense.
Yeah, I mean, not only just it's useful for research like yours for us to collect it and to track it longitudinally, even for that, and then also certainly for like the individual patient case and care. And I was just, the whole thing about necrosis, because certainly that does seem like a meaningful marker to understand the response to chemo. But as you pointed out, it doesn't necessarily correlate to prognosis. And it seems like there are, these other biomarkers that might do a better job of that. So it'd be interesting to see, hopefully that kind of happens sooner versus later, kind of moving in that direction. I was going to say we had a couple other questions come in. So one was says striking that the expression doesn't necessarily track the copy number variation, and what is known about the mechanisms of MYC dysregulation in osteosarcoma. So because the expression doesn't necessarily track with the copy number changes.
I think that this is a field of active research that and an area of real interest for the Sweet-Cordero lab and for others in the field. I think we don't know the exact mechanisms of MYC regulation. Certainly, some of it seems to be happening at an epigenomic level. There was a recent paper that just came out earlier this month showing prognosis defined by different methylation groups. So I think the methylome is another area of study to integrate with how it relates to gene expression at the RNA level and at the DNA level. So I don't know yet, but I share your eagerness to explore what those mechanisms are and then to ultimately leverage them to try and to target MYC.
And then a couple questions coming in about treatment related. So on that question about the CDK4, someone asked, it looks like palbociclib is an approved CDK4 inhibitor in other cancers. Would that be potentially relevant for MYC amplified patients?
I think we're still learning for which subset those CDK4/6 and there are some other related compounds that are in the preclinical pipeline as well as in the clinical trial landscape for other tumors. I think that there is going to be a subset of osteosarcoma tumors that are responsive to palbo and related drugs. I'm not sure yet if it's the MYC amplified subset, if it's those with CDK4/6 alterations. RB1 status is important there. So I think we really need to take into account not just sort of one alteration in a vacuum, but kind of their entire oncoprint or each individual's genomic landscape to really make informed decisions about which drug therapy matches well. But we, in the preclinical setting, are actually looking at CDK4/6 and 2,4/6 inhibitors right now in the MYC amplified and non-amplified setting in the present and in the coming weeks and months. I hope to have an answer.
Great. And then another question with very high MYC, should chemotherapy not be given and some other treatment tried? Kind of talking about the risk stratification and implications for treatment.
I think that's a really great question. I think we don't have enough data, unfortunately, right now to suggest a better regimen than MAP, even for the MYC amplified subset. And there is a subset of MYC amplified osteosarcomas that actually do surprisingly well. So we don't know the whole story. I think if we had another regimen that we knew was going to work, I would say absolutely, let's stop doing the same old thing and do something different. My hope is that we will design our next phase of clinical trials to say patients with MYC amplification should be treated with something different, be it the MAP normal backbone plus something else, or tweaking something different to get at their specific biology. But I think right now to do that off trial without evidence for a better regimen is tricky. But again, I'm hoping that we'll be able to offer at first different experimental therapy and hopefully therapy that will become integrated into standard of care down the line for patients with MYC amplified osteosarcoma.
And just circling back to kind of that earlier question about like how common MYC is in other cancers. And I think you said it was about 28%. And I know osteo is kind of very much its own beast, and it's so heterogeneous. But just because it is, present in so many other cancers in larger numbers, I'm just wondering what we can learn from kind of those studies in that world, given that there's so many cases, that we can then kind of take that learning and apply it to osteo, just because just the numbers are greater, right, in terms of just everything, samples, patients, data, and how that can kind of, help our learning for osteo.
I couldn't agree more. I think we should be really capitalizing on all of the data that we have and thinking about cancers as in some ways as molecularly defined subgroups. And so I think every bit of information that we learn about MYC's role in other cancers, we should be then taking back to our benches in the osteosarcoma world and into our clinics and seeing how whether that upholds in the osteosarcoma setting. But none of that ought to be discounted. And I think that drugs targeting MYC are much more likely to be studied first in MYC amplified adult and other more prevalent cancers, and that we should learn from those, and we should be quick to act on successes there, and think about in cases where it didn't work, why, and understanding the role in other tumors, probably the ways in which it regulates the tumor microenvironment in one cancer. There's at least some overlap in the osteosarcoma world. So I think we should not limit ourselves to our numbers and really leverage everything we have.
Yeah. Thank you for all your work on this and for a really interesting presentation, and most of all for your commitment to pediatric oncology patients everywhere. More information on this and all OsteoBytes can be found on our YouTube channel, on our website, mybagents.org, or your favorite podcast place. And if you registered for this OsteoBytes, you'll get an email with all the information and any other links mentioned today. And next week, we'll be talking with Dr. Vishu Avutu from MSK, Memorial Sloan Kettering, about an early phase clinical trial for patients with metastatic osteosarcoma targeting the DNA damage repair pathway. It's a phase 1/2 study of ZN-c3 plus gemcitabine in relapsed or refractory osteosarcoma. Thank you again to Dr. Marinoff and to our sponsor, BTG Specialty Pharmaceuticals. Thank you so much, Dr. Marinoff. This was really great info. Really appreciate it. And by the way, another plug for Factor. I think Dr. Marinoff is going to be there. So more questions about MYC, she's going to be there. You can ask her more questions. And thank you all for joining us today on OsteoBytes. And we hope to see you next week when we chat with Dr. Avutu. Thanks so much.